in palliative care. And this is really making the business case for palliative care and why we should be integrating palliative care within the healthcare systems, especially low and middle income countries. So thank you, Dr. Bates, and over to you. And it's really a pleasure having you with us. Just as one of the housekeeping things, if you want CPD points, please just put your Health Professional Council number in the chat. Thank you.
Great, thank you very much, Renee, and thank you for the opportunity to present to the department today. It's a great honour and privilege. I know you've got a lot of things coming up in Cape Town in the next couple of weeks, so it's very kind of you to make time today for this presentation. I've got a short film to start with, and Lindsay very kindly is going to help us with that. So I'm hoping that you can see this first slide, and the film is just about 3 minutes long, and just a summary of some of the work that I'll be sharing in a little bit more detail with you after that. So yeah, Lindsay, if you'd be kind enough to press the play button, we'll watch this and then I'll share my screen after that. Thank you.
Lindsay, we can't hear anything. I think you must unmute.
Households affected by life limit.
Sorry, I will start again.
No one really wants palliative care, or do they? Palliative care reduces the serious health-related suffering of adults and children in households affected by life-limiting illnesses such as stroke, cancer, and heart failure. It is integral to universal health coverage. The World Bank and others endorse palliative care as a value for money intervention, which supports poverty reduction at household level. Despite this, access to palliative care remains at critically low levels in most low and middle income countries around the globe, and its role remains widely misunderstood in global health. We undertook research in Malawi, a low-income country in South Central Africa, with patients and families who had experienced a diagnosis of advanced cancer. They used photo voice to tell the story of their illnesses, how they understood well-being, and the
Lindsay, you've muted again.
when her leg starts to swell. After several trips to the hospital, she is told she has advanced cancer. More visits to hospital means more money for transport and to buy some of the medicines the doctors ordered. Minika stays at home, no longer able to work or walk because of her painful swollen leg. The community-based palliative nursing team sees Minika, and following assessment, she starts taking oral liquid morphine, which helps to reduce her severe pain. She finds courage to start working again, and her children return to school. We conducted a study in which we asked 150 households to record where they went to get help and how much it cost them. We measured out-of-pocket costs following a diagnosis of advanced cancer, looking specifically at what happens when households receive palliative care. We proposed that out-of-pocket costs could be reduced by controlling symptoms and through patient-centered communication, reducing the need for beneficial care. Take, for example, Jeff. Jeff is 50 and he is bedridden with a brain tumor. His family members are trying to decide whether to sell some fields and a truck from their maize business to pay for him to travel outside the country for treatment. With the help of the palliative care team, they arranged to visit the village elders to discuss how best to support Jeff with his advanced illness. The family decide to care for Jeff at home, allowing him to die young rather than spending money on non-beneficial costly care. In our study, we found that almost 2/3 of households faced catastrophic out-of-pocket costs following a diagnosis of advanced cancer compared to less than half when they received palliative care. but only 1 in 5 households with advanced cancer received palliative care. Investment in palliative care reduces suffering and promotes future household health and well-being. No one really wants palliative care, or do they?
Great, thank you, Lindsay. If you could stop sharing and I will share my slides just now. That was really by way of introduction to this talk, which, as you know, is entitled Building a Business Case for Palliative Care in Low and Middle Income Countries. I just to sort of talk a little bit. Oh, my slides are failing to progress. Oh, here we go. Yeah. Hopefully you can hear me. Just as an overview to the talk, I'll first do a couple of background slides thinking about why we need a business case, and particularly thinking about the global access abyss for palliative care. There has been a lot of progress made, and I'll show a couple of examples of how things are really progressing in order to improve access to care, and then move on to the issue of building a business case, and particularly focusing on the areas of research which I have been involved with, prospective study looking at catastrophic costs and palliative care, and then briefly about a photo voice study which I undertook looking at understanding household well-being and things about measuring well-being. So that's what we'll be talking about, or I'll be talking about in the next 20 minutes or so, and then hopefully there'll be some time for questions after that. As Renee said at the beginning, I am a family medicine doctor, originally trained in the UK. Malawi in the South Central African region has been my home for the last 20 years. I'm currently speaking to you from the UK, which is where I relocated last year. But before that, I was working alongside colleagues in an adult palliative care clinic in the government teaching hospital in Blantyre in the south of the country, and also involved in the academic department of family medicine at the Kamuzu University of Health Sciences. And of course, I need to show you a quick photograph of our very beautiful lake to make sure that you will make time to visit Malawi, which is closer to you than it is to me today. So if we think about why we need to make this business case for palliative care, well, the real driver for us is what's been described by the Lancet Commission on Palliative Care and Pain Relief, which was issued in 2017 as an access abyss. And this is a very well-known infographic from that landmark publication, which is really demonstrating access to oral morphine, immediate release morphine. We know that around 50% of the world's population consume only 1%, have access to 1% of the world's morphine. So there is a tremendous disparity in terms of access to care, whether measured through access to oral liquid morphine, or we look at service delivery. So this is the problem that we have, and this is something that many of us are trying to work towards. Many people who are on the call today have done tremendous work in this area to try and make progress towards improving access to care across many countries where people struggle in need. So one of the major steps forward in terms of progress was the World Health Assembly resolution in 2014, the first ever global resolution on palliative care, looking both at the gaps in access, but also some of the excellent models of palliative care that were being developed in low and middle income countries, looking at some of the policies that were developing and the importance of integrating services throughout the life course. So this was a tremendous success for those who've been advocating internationally for palliative care over many years. And since 2014, I've already mentioned the Lancet Commission, which came out in 2017, publications such as the Global Atlas of Palliative Care. This is the latest edition from 2020, which really highlights some of the successes, also the continuing gaps. And the World Health Organization have recently, within the last couple of years, published excellent summaries of indicators so that we can start to really think about how to measure palliative care globally, and also looking at quality health standards. So there's been a lot of progress in terms of some of documentation and thinking around what we need to do to improve access to care. And of course, a massive success for those advocating for palliative care globally was the inclusion of palliative care in the United Nations definition, within the United Nations definition of universal health coverage. This is from 2019, looking at their understanding of universal health coverage to provide access to care, including promotive, preventive, curative, rehabilitative and palliative essential health services. So this has really helped us to move forward the call for palliative care, and also holding governments accountable to to their palliative care services as they want to progress towards providing universal health coverage. So this has been a massive success in that drive towards improving access to care. But there is still that need to build a business case, particularly, and this quotation, which I found quite helpful, comes from a US publication looking at building a business case for palliative care, thinking particularly about these issues as it relates to care in the United States, and pointing out the fact that it's critically important that we don't just talk amongst ourselves as palliative care providers about how important it is or what a good job we're doing, but we need to really be able to engage key stakeholders, health system administrations, physicians who are saying payers, and particularly looking at this issue of financial viability of palliative care programs. And huge work has been done, particularly in the United States, looking at the business case, because I think we still do have somewhat of an image problem in palliative care. We have to face this. Many people are not keen to talk about end-of-life care or to think about healthcare beyond curative kind of paradigms. So we do still suffer from this, and I think that will always be the case. And for those of us in palliative care, often we are comfortable with talking about terminal care or end-of-life care, or even talking about death. But this is not necessarily something those in the health sector would expect themselves to be talking about, and we do have that image problem. And within the United States, the way that they have very successfully built a business case is particularly by looking at health system costs. So focusing on health system costs and looking at how the provision of palliative care within hospital settings has reduced costs to health systems. And this has been documented across many settings and has resulted in a huge expansion of palliative care, which prior to that was pretty much focused only around hospice care and only around patients who had a prognosis of 6 months or less. And now people are able to access palliative care much earlier in many hospitals. Again, there'll still be gaps, but this economic argument that was made has resulted in a massive expansion in access to care very successfully. But of course, the United States has a very specific system of health financing and healthcare provision, and we need to look outside of the US if we're trying to understand what might be more relevant for those of us who are working in and focused on low and middle income country settings. And this is a very interesting paper from the Action Study Group, and they looked at around 9,000 patients across a number of Southeast Asian countries, looking at health expenditure and outcomes 12 months after a diagnosis of cancer. And results from that study found that the vast majority of patients had either died or face financial catastrophe 12 months after a cancer diagnosis. And we know that particularly this is now looking beyond health system costs to thinking about from a societal perspective, looking at out-of-pocket expenditure. So out-of-pocket expenditure as well as biomedical death outcomes are huge and have huge implications for family members. And just to illustrate this with a short patient story, this is from a report which was submitted by colleagues of mine who were visiting a patient at a district hospital in northern Malawi, looking at a patient who had been sick for a very long time, had been to a number of expensive private hospitals for care for his Kaposi sarcoma. His pain and symptoms hadn't been well managed, and he had ended up spending with incurring very high out-of-pocket costs before he was able to meet a palliative care team. And these kind of stories are not unusual, unfortunately, in our settings. And as we know, in low and middle income countries, we're not just looking at the individual when we're thinking about out-of-pocket expenditure. The expenditure that is incurred has an impact on the whole household. So as household income is reduced, if we look at this part of the cycle, this results in reduced household well-being. That can also have knock-on impacts, looking at costs for education and training, and maybe even early school dropout, as children have to be taken out of school to care for their family members. And then it's sort of a cycle whereby then people present late with disease and experience further high levels of catastrophic costs. So one of the ways that palliative care can interrupt this poverty cycle is to treat pain and to provide information as a kind of basic minimum package of palliative care, so that if pain is treated, people can return to work, whether it's the patients themselves, if they're able to do that, but the caregivers can return to work rather than staying at home, having to manage the patients full time. And the other key thing that we found in a study, which I'll present later, in terms of improving well-being, is the importance of reducing discrimination and enabling people to function as part of the community, even when they have advanced disease. So there are ways in which sort of theoretically we can think about palliative care interrupting a poverty cycle. And the issue of financial protection and reducing out-of-pocket expenditure is integral to our to the goals of universal health coverage, which obviously are looking at access, looking at quality, but also looking at financial protection. So if we're thinking about palliative care within universal health coverage, this element of out-of-pocket expenditure and trying to protect people from excess out-of-pocket costs and catastrophic expenditure is critically important as part of providing universal health coverage. So I'll now just briefly talk about a couple of areas of study which I was involved with. Firstly, looking at catastrophic costs and palliative care, and then briefly I'll talk about some qualitative work on household understandings of well-being. So I undertook a prospective study of household well-being and poverty status, looking at palliative care within universal health coverage. And this was in 2019, and we approached 156 households following a diagnosis of advanced cancer, and 150 patients and 121 family caregivers were recruited into this study. And we gathered data on the healthcare that they had received, looking at when the symptoms had started and when they'd been diagnosed, so the gap between symptom onset and diagnosis. We looked at costs between in those times, but also we measured the healthcare received at 1 month, at 3 months, and at 6 months. And we asked them to report out-of-pocket costs involved in the healthcare that they'd received. We also asked them about dissaving, so any loans or sale of assets that they had to undertake in order to meet the costs of healthcare. And we measured well-being using the Euroqual EQ5D, and also measuring, also using the integrated palliative care outcome scale. The cost tool which we used to gather this data was adapted from the WHO TB patient cost survey, which some of you will know it's been used internationally probably for the last 20 years, and it's been used very successfully by those involved in the End TB campaigns to try and make arguments around reducing catastrophic expenditure for patients with TB. So part of the work which I was involved with was adapting the WHO TB patient cost survey to a group of patients with advanced cancer. So obviously with this patient group, we're going to have a fairly high attrition rate as expected. So we started with 150 patients and 121 caregivers. And by the end of the study period, which was at 6 months, we had 89 households still within the study, accounting for 89 patients and 69 carers. So that was the group that we were reporting on in terms of their costs and whether they'd received palliative care. So you'll probably recognise this as a data graph, and we broke things down looking at direct costs, so out-of-pocket costs for medicines, for transport, and for other direct costs of hospital care. We also looked at indirect costs, so we calculated this both based on the kind of mean looking at people's individual wages, self-reported incomes, but also on a minimum wage package at the time, and also asked people to report on their dissaving, which you can see was fairly significant. So loan requests and sale of assets. So just as raw data, this is how it presented, but obviously we needed to take this raw data through multiple linear regression to correct for a variety of confounders. So what we found in terms of the mean difference in total household costs on cancer-related healthcare, for those who'd received palliative care, it was 36% less. But this was a non-significant reduction compared to those who had not received palliative care. And part of the challenge that we had with this, as was outlined in the film, was that only 1 in 5 households received palliative care, even though we were working within a hospital which had a very well-established team and it had well-established referral pathways. So, but that did affect the powering of our study. We also used the data to calculate catastrophic costs, and we found that 64% of all households experienced catastrophic expenditure, and that was defined as a 20% or more of total household income. And so those households that had not received palliative care, that was 47%, 69% of those households who did not receive palliative care experienced catastrophic expenditure, as compared to 47% of those who had received palliative care. So this is kind of, I would call it early data, an example of how we could gather data around costs for vulnerable households. The difference in dissaving for those that had received palliative care and those who hadn't was a significant difference, but the actual level of catastrophic expenditure was non-significant, as was the total reduction in healthcare costs for those households. So certainly further work needs to be done, but this was an example, and we were able to publish it in Lancet Global Health in 2021. So just before I finish, I'm going to just briefly talk about measuring well-being. I suppose one of the important things for us to recognise is that one of the ways that households can reduce costs is just by not having any care at all. And clearly that's not something that we would want to bypass or kind of misunderstand when we're looking at reduction in costs. We need to always ensure that palliative care is delivering an improvement in quality of life and in well-being. I guess I've always been fascinated by this particular method. I'd heard about it several years ago as a method used amongst Native Americans looking at NCDs, I think. And I was very keen to use photo voice to explore well-being, and so we used it with 9 households who'd received community-based palliative care under our community-based programme just outside of Blantyre. And we met together for over a period of a month, and patients and family caregivers were taking photographs of the story of their illness. They brought the photographs together, discussed them in groups. They did participatory analysis of the photographs. They did some captioning of the photographs supported by one of our qualitative researchers. And from that, they gathered their photographs and were able to do a photographic presentation of the captioned photographs as part of a presentation to policymakers, to local tribal chiefs, and also to the district health officer in the area. It was a tremendously energetic process and very exciting. I think I found it very exciting, and I think it was very well attended by all the co-researchers, and certainly I would recommend it as a participatory method if you are interested in that. And the findings from that are were published in PLOS One back in 2018. But just from the results abstract of the paper, one of the areas that we were looking at was thinking about how palliative care contributes to an improvement in well-being. And I think it is important and somewhat different, say, to first world settings, that it's perhaps certainly in Malawi less about preparing for death and the end of life, but more about the contribution of pain relief and symptom management, enabling people to function for as long as they can, particularly earning money and feeling useful. I think it seemed to be very important to the participants as one of the themes that emerged, and the theme of discrimination was used by the co-researchers as the main theme for our policymaker meeting. And that was something that I think I hadn't fully grasped and was very interesting to learn about through this particular study. Of course, in terms of building a business case, there are many other things apart from just the financial case. We need to think about outcome measures. And as I mentioned, these financial issues are not just affecting individuals, but really looking at well-being of households and communities in our settings. And health systems strengthening, and the role of palliative care as within integrated palliative care within health systems strengthening, I think is critical for us to look at. Looking at health systems financing mechanisms, I think we need to understand this more in palliative care. There are some models emerging. I think from Rwanda is a case, Thailand is another case, where they've managed to move beyond some of the dependency on donor funding to really integrate into some of the government and domestic finance mechanisms. And of course, we want to make sure that as we build a business case, we also remember the needs of particular populations, thinking about children and humanitarian and conflict situations. And of course, it's good to be addressing a multidisciplinary department with many research interests, because I think it's becoming clearer and clearer, if it wasn't clear already, that we need to work as palliative care researchers within and as part of multidisciplinary networks. There are many interesting areas of research. I'm able to integrate with a stroke care research group. I think we've just recently heard that we may be able to do some a step wedge study looking at stroke care. Obviously, stroke outcomes in low and middle income countries are very poor, and we need to ensure that palliative care outcomes are measured and costs are measured within some of those research outcomes. I know Lindsay and others have done very interesting work looking at post-TB, lung disease and COPD. So I think this is becoming, we are getting better at integrating our research, but we need to do more of this. So in order to build a business case, lots of work done, lots of work to do, and plenty of progress made. And it's critical that we have the support of the WHO, who see palliative care and palliative care research as an opportunity to renew that commitment to reducing the global burden of serious health-related suffering. And it's really our hope and our desire to see serious health-related suffering at the patient and carer and household level reduced as quickly as possible in the years to come. So thank you very much for listening, and I will hand over to our Renee and Lindsay. I haven't been watching the chat, but if there are any questions or comments, I'd be delighted to hear them. Thank you very much.
Thank you very much, Jane. What an excellent lecture. And the hands are going up. So can we start with Jeroen, and then we can go to the questions in the chat as well. So Jeroen, first question to you.
Thank you, Jane, for the great talk and for those insights. I just wanted to ask you sort of an unusual question maybe, but I mean, we have obviously our traditional Western sort of approach, and within that, different religions and you know, that variety. But in terms of your experience, what are maybe some of the highlights of unique sort of cultural approaches that you've seen to the whole process that you're involved in and palliative care?
Jeroen, would you mind telling me your background? It's partly for me to learn who's in the department, but
sorry.
Also,
I'm head of sport and exercise medicine, so I'm from the sport and exercise medicine division, which is part of the FACE department. So,
Sure.
so that's in the very short background.
Yeah, thank you. No, I mean, it's a fascinating question, and I think there are many cultural, religious, and other particularities that we need to think about. I mean, one of the interesting things, I suppose, that say from the studies which I did, the prospective study, the average age of patients was 50, the average age of caregivers was 40. The disease spectrums are different, and the role of spirituality and the expectation of healing, those would be kind of highlights, I suppose. Now that I've never done palliative care in the UK, but I'm now working with the University of Lancaster and having to sort of quickly become a bit more familiar with the priorities here. And I think that there's a tremendous individualism in terms of cultural practice here. I'm maybe less qualified to talk about UK than I am about Malawi in a way, but obviously it's looking at older people, a very individualistic society, perhaps less religious faith overall. I mean, there are obviously a variety of spiritual and religious traditions that people would see in the UK, but and a lower, I mean, there is out-of-pocket expenditure, but I think somebody commenting on a tool they were developing to gather costing in the UK, they were actually thinking about, because UK healthcare is state funded, then actually a move to home for a patient and a family could potentially increase their costs because because otherwise, whilst they're in hospital, they don't experience so much out-of-pocket expenditure as you would in Malawi, where a lot of the expenditure is out of pocket. And again, South Africa is considerably it's a middle-income country, and so out-of-pocket expenditure may well be at a variety of different levels in a variety of different communities, because there's so much breadth within the South African context. I don't know. I mean, it's a huge question, and very interesting one. I don't know if that begins to give some pointers as to my thoughts. Yeah.
Thanks, Jane.
Thanks, Jane. There's a question in the chat from Dr. Nsiki Mapukata. She says, was the attrition due to the loss of life or withdrawal from the study? And was there a correlation between the household support and participation in the study? To what extent did the patient's personal belief model influence the participation or the lack thereof? So it's very much.
Yeah, we thank you for that question. It was through death, the attrition. We had 4% lost to follow-up, and we didn't have anybody withdrawing from the study. I think maybe because I was not involved in clinical care of the patients at all at that stage, but we were recruiting in a hospital setup which I knew, and the main research, well, I'd worked in for 20 years, and the research nurse was somebody well known to the hospital, and the field workers were very familiar with the environment. We didn't have a lot of problem with recruiting patients. Sometimes we had a bit of a misunderstanding about when we were asking people about costs, and we did talk to the people who had experience with a TB patient cost survey to see how they handle that. I mean, certainly we were gathering data also on funeral costs. And sometimes people were thinking, okay, that means, are you going to come in then with some money to pay for the funeral? Or, are you coming, are you asking us about costs because you're going to help with something, or because you're going to offer something different? So, we did have to be clear with patient information and take time to answer questions and, follow up on that. And we did some training about that, and we talked about that. And we also had to have distress protocols, obviously, for the field workers, because when they were doing follow-up, they quite often found that there'd been a bereavement in the household. So we had protocols so that they didn't feel exposed, and they could refer back to myself or the research nurse on the team, so that they got the support that they needed. But we didn't have a lot of loss to follow up. Yeah.
Thank you, Jane. And there's another question from Richard Harding.
Hello, lovely to see you all. Thank you, Jane, for a fantastic presentation. So you are offering a really unique set of skills. There are few health economists in the world. There are even fewer working in palliative care, even fewer working in low middle income countries. So what you do is so important and valuable. And I think you've demonstrated that well. So for all of us out there who are saying, gosh, what Jane is doing is really important, we need to do some of that. What's your advice?
Thank you, Richard. You've always been very supportive, so thank you for that. And I think having the work which Liz has been doing around the WHO, and some of us have been involved with the WHO paper on economics of palliative care, drawing together some of these strands, looking at health systems from a health system perspective, looking at it from a societal perspective. I think that's a very valuable paper. I think we need to do more studies looking at some of, even sort of answering Jerome's question, thinking about the South African context, what are the drivers of out-of-pocket expenditure in a very different health service? Malawi is thankfully now one of the few low-income countries in Africa. Many countries are moving to middle-income status, and that may we don't really know what that means to expenditure. Is there more dissaving? Is there less dissaving? are people still driven to out-of-pocket expenditure? And I think, you know, there are a lot of things still to look at. We need to look at barriers, and I think one of the key barriers we haven't looked at, I apologise if anybody's done research that I haven't read recently. It's always dangerous to say there's no research about something when you're talking to academics. But anyway, is around health worker barriers. So that kind of image problem that we have, and the integration aspect. So for people who are kind of fundamentally, you know, respiratory physicians, and how are we going to make sure that patients get access to early palliative care from a respiratory physician flagging that need and being able to transition a patient quickly into palliative care. So that's I suppose that's less what you're talking about. You're talking more about the health economic side. I think we need more data. I mean, it was, you know, in a sense, I suppose that's what my research began to show, is that, you know, and we need to be, what I can say is that it's as, and I think, as you know, I've experienced in the work I've done with you, is that it's quite difficult to translate from one setting to another, even the cost tool, because of this issue of when do people start palliative care. And getting cost tools that are suitable for different patient groups. So we need to cost stroke, we need to cost heart failure, we need to cost, you know, a variety of non-cancer diagnoses. So, yeah, and thinking about how we gather that data, and probably thinking about how we simplify some of that data, because the cost tool, you know, was quite long. And are there ways that we can almost embed some of the questions about cost? You know, this is something that when I presented some of this data in Malawi, my colleagues in obstetrics and gynecology, they obviously deal with a lot of patients with advanced cervical cancer a lot of the time, and they sort of suddenly thought, oh, maybe we should ask our patients, you know, can they afford, you know, have they got enough money for the transport to get to the clinic today, as an indication of whether they're going to make it to the follow-up. Because loss to follow-up from oncology care is huge in Malawi because of expenditure, you know, transport costs are too high. But we don't think about costs at the patient interface, you know, often enough. And that could potentially be done quite simply. So I think there's so much that needs doing, Richard. And maybe I need to be, well, as I think, you know, I'm hoping to write this up. So thinking a little bit more within that write-up of a business case as to a way forward, and making that very clear, and sort of trying to map out some of these areas, because I think there is a lot to do, and lots of potential and possibilities. Yeah. I'll stop there.
Thank you, Jane. And I think the importance of doing this research in our context is vital. And I think we've taken quite a lot from you on this, but I think Liz has got one more question. Liz?
Jane, thank you very much for a wonderful presentation and for all this really important work that you're doing, because you've spoken about the fact that acceptance and the image of palliative care is something we have to work on, but the funding aspects are so critical. And I think that we've moved from the time when no care is seen as the option, to a time in low middle income countries where the option is now home-based care with community care workers, maybe nursing care providing palliative care, and governments or health facilities seeing that as being the less expensive option. So my question is around the importance of having, in the African setting, specialist palliative care. What is the economic advantage of having like a palliative care program at a hospital, or specialist palliative care clinicians, whether doctors or nurses, to help provide the services? Or is it cheaper to go with the home-based care, community care option? Cheaper or and as effective, because we have to think about the impact and the patient outcomes.
Yeah. I mean, I'm sure that's again a group, you know, a kind of question that others probably would also have valuable input. I think if, you know, my thoughts would be yes, and we need both and, don't we? And clearly community options are going to, and home-based care is going to provide access close to people, so it's going to reduce the costs in terms of transport and so on, and is very relevant. It's going to be, you know, hopefully more cultural, or hopefully culturally appropriate, so you know, integrated in those settings, absolutely vital. The challenge for those of us involved in particularly opiate prescription is that there is a need for expertise, even if we're not getting as complex as opiate rotation, but even to prescribe immediate release morphine is not something that a community worker can do or monitor. They obviously can play an important role within that, you know, within the delivery, administration, whatever, safely of morphine. But if we consider that relief of serious, you know, I would consider the center of reducing serious health related suffering is the relief of pain, and central to the relief of pain is the availability and access to immediately release morphine. So at that level, we need to have expertise from nurses, yes, mainly, and then with some physician input. And it, you know, it's about pathways into care. So, you know, if we only have community-based services, there will be, you know, patients from the hospital who are going home who will never have heard about palliative care, will take, you know, months to find their community-based workers. But if you've got care in the hospital, people can be stabilised and travel then with care to the community health workers who can continue that, who understand what they're continuing and why they're continuing that. Then that's kind of what you need. So you need the pathways and appropriate, and that's appropriately, and of course it's going to depend on, you know, your health financing and your budgets within country as to how many specialist palliative care teams you have and where you have them and what they provide. So there is going to be nuance and there is going to be difference, and that's exciting. It's quite difficult when you're writing about it, but when you think of, you know, that in a sense is why it's almost a mistake to talk about low and middle income countries, because within that there's so much variation, and within one country, I mean, I don't know a lot about South Africa, but I've worked there a little bit, and you know, so much variation within one country, and sometimes when we write about that, it's not clear to people outside of our settings of low and middle income countries how much difference there is in all of those areas: health financing, health provision, numbers of health workers, numbers of community workers, all these issues, religious, cultural variation. But I mean, it has to be both and, really. Yeah.
Thank you, Jane.
So definitely from our experience here in Cape Town, it can't be one or the other. It is, as you say, the pathways and ensuring the continuity of care. But what I from Prof. Reed, he asked here that catastrophic expenditures can be due to perverse incentives of private practice, together with the reluctance of most medical practitioners to hold the difficult conversations with the patients or the family. Has this been at all your experience when you reviewed the causes of these expenditures in your study?
Absolutely, absolutely true, and we need to do some more work. I have looking at the breakdown, because we did obviously ask people where they got healthcare from. The majority of these patients were accessing cancer care through the government hospital. So some of them use private care. There's a less than 5%, maybe less than 2% of the population in Malawi access private care. So if you're looking at the Malawian context, and particularly this study population, they're not a population that would be accessing a lot of private care. But we did try to start a fee-paying palliative care service in Malawi to try and be income generation for our government service. But we found exactly that the private hospitals were not willing to refer to palliative care. We made the argument to the medical aid societies that they would have to shell out less if they could, create a pathway into palliative care. But actually, we found the specialists were unwilling to refer to palliative care. They wanted to hold on to their patients. And so, yeah, I think that's a major barrier. I think both of those things that Steve has mentioned are enormous and, require training, require awareness raising, require more research on our part. And to be honest, on the part of there's quite a lot, isn't there, out there in the oncology literature, but probably not again from our settings. So yeah, more work to do. Yeah.
Thank you, Jane. And I'm going to ask the last question. How is palliative care currently funded in Malawi?
So the palliative care that's in Malawi is funded by the government. We've kind of it's not included in the latest strategic plan. However, there are indicators for palliative care, and because there are indicators, that means that the Ministry of Health have to collect data on palliative care provision. So that's been I suppose where we've found our success. And because we had the sort of small model of palliative care, we started in the government sector, in the government teaching hospital, and then that was cascaded out to district hospitals, and we had a lot of support from the Palliative Care Association of Malawi, a lot of support via them, from the Ministry of Health, from a desk officer who was very passionate about palliative care. Those indicators came in, and then that's kind of helped to get some basic kind of reporting and basic palliative care. Obviously, we need to continuously look at quality, continuity of services, because people can, report on numbers, but actually what's the quality of the service is a slightly different question. Yeah, so it's publicly funded. There's nothing outside the public sector. Yeah.
And I think you highlight such an important question, is how important it is actually to measure palliative care in a country, because it is a very good integrating structure. Thank you very, very much. Are there any further questions? Okay. I think that brings us to the end of this lecture, and really a fascinating talk. Thank you very much. And thank you for talking to a multidisciplinary team. And I'm very glad that we've really had a multidisciplinary team attending this lecture in really raising awareness of palliative care, and especially ensuring it's integrated in the care we are providing. And thank you for being such a great advocate for palliative care, not only in Africa, but across the world. Thank you, Jane.
Thank you very much.
Thank you very much.
Thank you.
Thanks, Jane.